Welcome to the Deep Dive. Today we're tackling something you might have wondered about if you know anyone dealing with narrowed kidney arteries. Renovascular disease.
Right.
Endovascular treatment, like putting in a stent. It sounds great, doesn't it?
Right.
Less invasive, quicker recovery.
Yeah, that's the appeal.
But is it always the best move? That's what we're digging into today. We've got a stack of textbook chapters here on vascular and endovascular surgery. And our mission, to figure out the real story, the complexities, maybe the controversies around this treatment that seems so straightforward at first glance.
Exactly. It's fascinating because, like you said, the minimally invasive idea is really attractive. Compared to open surgery, you'd think, well, less risk, faster bounce back, less hospital time.
That's the picture, yeah. A compelling one.
It is.
Okay, so if that's the appealing picture, what's the catch? What are we not seeing initially?
Well, the big thing is, despite how intuitive it feels, the best evidence we have, the gold standard level A data from big studies, it actually doesn't broadly support just stenting these arteries as being super effective across the board.
Really? So the big trials haven't shown a clear win?
Not for widespread use, no. We've had several major studies looking right at this.
You mean like Drastric, ASTRAL, STAR, Corral, those ones?
Precisely. Drastric was early on, late 90s. It had some issues, patient crossover and stuff, but didn't show a huge improvement in blood pressure with angioplasty.
Okay.
Then ASTRAL and STAR came out of Europe, late 2000s. Their main message was pretty clear. No strong evidence to routinely use stents for renovascular hypertension or for kidney damage from low blood flow, ischemic nephropathy.
Weren't there some criticisms about how those trials were done, though? Like limiting how much we could generalize?
There were, yeah. Methodological critiques, definitely.
Yeah.
Some argued the patient groups or methods limited the conclusions, but then came Corral.
Right, the North American one. That was supposed to be more robust.
Exactly. Considered the most rigorous trial. And guess what? Same story, pretty much. No overall clinical benefit for routine revascularization in patients with significant stenosis and high blood pressure, even if they had kidney dysfunction.
Wow. So even if the artery looks really narrow on the scan, putting in a stent might not actually lead to a better outcome than just good medical management for many patients.
That's what the evidence strongly suggests for the average patient in those trials. And what's really interesting, they dug deeper into the Coral data and other studies too.
Trying to find predictors, like maybe if the pressure drop across the narrowing is big or the BP is sky high.
Yeah, they looked at all that. Translesion pressure gradients, baseline BP, protein in the urine, how severe the stenosis was, even fractional flow reserve.
Yeah.
And, well, none of those factors consistently pointed to who would actually do better with a stent versus just medication.
Huh. So it's not just simple plumbing, fix the blockage, and everything gets better.
It really doesn't seem to be that straightforward for many.
But you mentioned exceptions earlier. Cases where the guidelines do still recommend intervening.
Yes, and this is key. Despite all that data questioning routine use, the guidelines definitely identify specific situations. We're talking patients with what we call hemodynamically significant stenosis, meaning the narrowing is really impacting blood flow and they have severe hypertension. That's just really hard to control.
Okay, so not just run-of-the-mill high blood pressure.
No, really difficult cases, sometimes with kidney problems alongside it, or when the hypertension is causing serious issues with the heart, like cardiac disturbance syndromes.
So these are patients who probably weren't the typical ones enrolled in Coral.
Exactly. A much more specific, often sicker group. So maybe we should dive into why intervention might still be on the table for these folks.
Yeah, let's do that. Let's talk about those really tough hypertension situations first.
Yeah.
The ones not responding to multiple drugs, causing heart problems, or those scary sudden spikes.
Right, those hypertensive emergencies, sudden severe BP spikes causing acute organ damage, like flash pulmonary edema, brain swelling, heart attack, acute kidney failure. That's a different ballgame. Intervention might be considered there.
Okay, that makes sense. But what about just chronic, really high, hard-to-treat blood pressure?
Even there, we have to remember ASTRAL and Coral. They found that even when stenting did lower blood pressure somewhat, it didn't necessarily translate into fewer cardiovascular or renal events compared to optimal medical therapy.
That still feels a bit strange. Lower BP should be better, right?
You'd think so, intuitively. But the underlying disease processes are complex. Atherosclerosis is systemic. Fixing one artery might not change the overall risk profile enough for many. So the trend now, it's really towards reserving revascularization for that truly refractory hypertension or cases where the BP is clearly causing end organ damage.
Okay, what about the other main reason? ischemic nephropathy, when the kidneys themselves seem to be failing because of the poor blood flow.
Ah, yes. This is a really challenging area. It makes perfect sense, biologically narrow artery, less blood flow, kidney damage. But proving definitively that the stenosis is the sole or primary cause of the kidney dysfunction in a specific patient, that can be surprisingly difficult.
It's not always a clear link.
Not always clear-cut, no. Kidney disease often has multiple contributing factors.
So how do doctors try and figure out if fixing the artery is likely to help the kidney function?
They look for clues, these predictors of response, things that suggest the stenosis is playing a major role, like a rapid decline in kidney function that's otherwise unexplained.
Okay.
Or if there's significant disease in the arteries to both kidneys, or in the artery to a single functioning kidney. Those situations raise the suspicion quite a bit.
Right, situations where the kidneys are really vulnerable to reduced blood flow.
Exactly. But here's a really crucial point from the texts. The strongest predictor of clinical benefit seems to be actual improvement in renal function after the revascularization.
So you do the procedure, and the kidney function measurably gets better.
Yes. If the eGFR improves significantly, that's a powerful sign the intervention was worthwhile for that patient. It suggests that maybe patients who already have kidney dysfunction are, potentially, the group most likely to benefit right now.
That's a very important distinction. Okay, so let's flip it. When should this not be done? What are the contraindications?
Good question. There are several reasons not to intervene, or at least to strongly reconsider. Some are purely anatomical.
Like the blockage is just in a bad spot.
Exactly. If the disease is in a location that's technically difficult to treat well with current endovascular tools, or where the long-term results are likely to be poor.
Can you give some examples?
Sure, like disease that extends right into the tiny branches beyond the main renal artery, or if the main artery itself is extremely short. Disease in those distal branches or in multiple small accessory arteries, these are technically challenging. Also, in children, the cause is often different, more developmental, like fibromuscular dysplasia or hypoplasia, not atherosclerosis. Endovascular treatment, especially stenting, raises concerns about long-term durability and growth. Open surgery might actually be a better, more durable option in many of these anatomical situations, provided the patient is fit for surgery.
Makes sense. You want a fix that lasts. Any other reasons to avoid the endovascular route?
Well, if a patient is already scheduled for open aortic surgery for something else, like an aneurysm.
You might as well fix the renal artery surgically at the same time.
Precisely. It can be more efficient and potentially more durable in that context. And then this is really important prophylactic treatment, what some call drive-by stenting.
Meaning you see a narrowing incidentally on a scan and just decide to fix it.
Yes. And the evidence here is crystal clear. There is no justification, no level I evidence to support routinely stenting renal arteries in patients who have normal kidney function and well-controlled blood pressure, even if they have some degree of stenosis.
Even if the narrowing looks significant.
Even then, we have to consider the natural history. For most people with atherosclerotic renal artery stenosis, especially if they're asymptomatic with controlled BP, the narrowing often doesn't progress much.
Really? It stays stable?
In many cases, yes. Significant anatomical progression only happens in maybe 10 to 30%. Progression to complete blockage, that's actually quite rare, maybe 0 to 7% in studies. And even when the anatomy does change, it doesn't reliably correlate with worsening blood pressure or kidney function. So given this often benign course, plus the risks of any intervention and the core results, a non-operative medical management approach is usually best for these asymptomatic, well-controlled patients.
Okay, that's a very clear message. So let's say intervention is deemed appropriate for one of those specific indications. How do we measure success, right after the procedure?
We look at it in two ways: technical success and clinical success. Technical success is about the procedure itself. Did we achieve the goal?
Meaning, did the artery open up properly on the angiogram?
Right. Typically defined as reducing the stenosis to less than 30% residual narrowing on the X-ray images. And if a stent was used, it needs to fully cover the lesion and be well expanded. They also often check pressures across the treated area.
Pressure gradients.
Yes. Ideally, the systolic pressure gradient should be less than 10 millimeters of mercury after treatment. If it's still high despite looking good angiographically, they might do more ballooning.
And clinical success, that's about the patient.
Exactly. It depends entirely on why we did the procedure. For hypertension, we look for improvement. Is blood pressure lower? Do they need fewer meds? Are they cured, improved, or did it fail to help?
And for kidney function?
Similar idea. Improved, unchanged, or worsened. We use measures like serum creatinine and uh, estimated glomerular filtration rate, eGFR, often looking for maybe a 20% or greater improvement in eGFR. Kidney size is sometimes tracked too.
But those immediate clinical measures don't tell the whole story about long-term impact, do they?
No, they don't. There isn't one single parameter right after the procedure that perfectly predicts long-term morbidity or survival benefit. Really, the most meaningful outcomes are things like survival free from needing dialysis, avoiding kidney-related death, and preventing major cardiovascular events.
Okay. What do the studies generally show for those immediate early outcomes? They're like within 30 days.
Generally, the technical success rates for RAPTS, that's renal artery percutaneous transluminal angioplasty, and stenting, are very high, often reported between 88 and 100%.
That's good.
And early mortality within 30 days is typically quite low, 0 to 5% in most series. Procedure-related complications happen, though. The reported range is wide, 0 to 43%, but in rigorous trials like CORAL, it was under 5%.
What kind of complications?
The most common in CORAL was actually artery dissection, a tear in the vessel wall during the procedure. But overall, technical success is high and early major problems are relatively low.
So the procedure itself often goes well initially. Let's talk long-term. What happens years later? Does the artery stay open?
Anatomic durability, meaning the stent stays open, or patency, can actually be quite good. Some studies report stent patency around 80% at 5 years.
Okay, that sounds promising. But what about the reason for doing it? Does the blood pressure improvement last?
That's where things get, well, less clear-cut. A complete cure of hypertension is pretty rare after stenting. Improvement is common, yes, but failure to significantly improve BP is also quite frequent.
Right, you mentioned ASTRAL and CORAL didn't show big BP wins over medication long-term.
Exactly. ASTRAL found no significant difference in systolic BP between stenting and medical therapy alone at 5 years. Maybe a slight dip in diastolic and a small reduction in meds in the stent group, but the clinical significance of that is debatable. CORAL showed only a small systolic BP decrease with no real change in medication burden.
And those factors people thought might predict a good BP response, like how bad the hypertension was or the stenosis severity.
Yeah, many of those reported predictors, severity, duration of hypertension, age, stenosis percentage, bilateral disease, female gender, BNP levels, they haven't really held up consistently across the board, especially in light of the big trials. And even if BP does improve initially after a stent,
It can creep back up over time.
it can, yes. That benefit isn't always sustained. So given ASTRAL and CORAL and the fact that lowering DP with a stent hasn't clearly linked to better event-free survival for most, well, the enthusiasm for stenting just for hypertension, especially with normal kidney function, is much lower now. It really should probably be reserved for those truly uncontrollable cases, maybe with target organ effects.
Makes sense. What about long-term kidney function? Does stenting prevent decline or lead to improvement over years?
The results here are really quite variable across studies. It's kind of all over the map. Some reviews find improvement is the most frequent outcome. Others find deterioration is just as common or more common. And many show no change is the most likely result.
So it's a bit uncertain.
It is. One weighted average suggested maybe 25% improve and 25% decline after unprotected stenting. So roughly half see no significant change or get worse.
What about slowing the decline? Even if it doesn't improve, does it stop it getting worse as fast?
That's been looked at using something called breakpoint analysis, looking at the slope of eGFR decline. And yes, stenting can sometimes slow the rate of decline in certain patients, but whether that slowing translates to a real clinical benefit is debated.
What did ASTRAL find there?
ASTRAL found no benefit of stenting over optimal medical therapy in slowing GFR decline. And actually, the medical therapy group in ASTRAL did better than historical controls. Their decline was slower than expected.
Why was that?
Probably reflects improvements in medical management, better BP control, statins, ACE inhibitors during the time the trial was running.
But you keep coming back to this point. If kidney function does improve after the procedure,
Yes, that seems to be the key. If you see that post-revascularization improvement in eGFR, that is linked to better long-term survival in several analyses. Just stabilizing function or slightly slowing decline, the survival link isn't nearly as clear.
are there predictors for who might get that positive kidney function response?
People have looked. Bilateral disease, higher baseline creatinine, advanced CKD, a rapid decline before the procedure, poor heart function, absence of metabolic syndrome, maybe kidney volume changes. These have all been suggested, but again, the strongest signal is seeing that actual improvement after the fact.
Okay. And what about the stent itself? Does the artery tend to narrow down again, restenosis?
Absolutely, that's a major issue. Renal artery and stent restenosis. The reported rates are incredibly varied in the literature, anywhere from 5% up to 66%.
Wow, that's a huge range. Why so different?
It depends heavily on how long they follow patients, what imaging they use, and exactly how they define restenosis. It seems to be more common in women, maybe those with metabolic syndrome, less common perhaps with statin use.
What causes it?
It can be technical issues with the initial stent placement, maybe it wasn't fully opened or got compressed by calcium, or it can be neointimal hyperplasia, basically, scar tissue growing inside the stent.
And how do you know if it's happening?
Usually, suspicion arises if the patient's blood pressure starts getting harder to control again or their kidney function declines. Restenosis is found more often when imaging is done because of clinical suspicion, rather than just routine screening in someone doing well.
So the fact that it can happen relatively often raises questions about the long-term benefit, right?
Huh.
Especially if kidney function didn't improve much initially.
It does. Frequent recurrence definitely tempers enthusiasm, particularly if the initial clinical benefit was marginal.
So the ultimate question, survival. What does a long-term data show? Does stenting help people live longer?
The really long-term data is still a bit limited beyond those main trials and some retrospective studies. Those retrospective looks suggested, unsurprisingly, that patients starting with worse kidney function or bilateral disease had poor long-term survival.
And not improving kidney function after the procedure was linked to needing dialysis.
Yes, that connection has been shown. There are also hints that using ACE inhibitors and statins after stenting might improve survival, while things like pre-existing heart failure, coronary disease, or COPD predict worse outcomes.
What did the big randomized trials show on survival? ASTRAL.
ASTRAL followed patients for 5 years. Overall survival was about 58%. But crucially, no difference between the stent group and the medical therapy group. That BP improvement and reduced med count in the stent group didn't translate to living longer, and no difference in kidney function decline either.
And STAR.
STAR had shorter follow-up, about 2 years. Survival was better, over 80%, but again, no difference based on whether their BP or kidney function responded to the procedure.
Okay, so the survival benefit isn't clearly there for routine stenting based on the best evidence. Let's shift to the procedure itself. What are the key things to know about actually doing the angioplasty or stenting? Anatomy must be important.
Absolutely critical. The renal arteries usually come off the aorta at a bit of a downward angle, so you need oblique or angled X-ray views to see their origin clearly.
And not everyone just has one artery to each kidney, right?
Correct. Multiple renal arteries are pretty common, maybe in about 18% of people. Ultrasound might miss smaller accessory ones sometimes. The main artery is typically 5-6 millimeters wide distally, and you often see the artery widening out a bit after the narrowing post-stenotic dilation.
You mentioned contrast dye earlier and the risk to kidneys. How is that managed?
Yes, contrast-induced nephropathy is a major concern, especially with pre-existing kidney issues, diabetes, heart failure. So you use low osmolar contrast, keep the volume absolutely minimal. Prehydration with IV fluids is key before, during, after.
Can they use anything else if the risk is really high?
CO2 gas can be used as a contrast agent in severe kidney dysfunction, but it gives a different kind of image, less detailed in some ways. Careful hydration is probably the most important preventative step.
What about medications around procedure time?
Usually hold NSAIDs, diuretics, metformin.
Yeah.
Maybe adjust anticoagulants depending on the situation. Continue the regular blood pressure meds. Pre-op aspirin and a statin are standard now. And then dual antiplatelet therapy, usually aspirin and clopidogrel, for at least 30 days, maybe longer, after stenting. Aspirin and statin are usually indefinite.
And the choice? Just balloon angioplasty or always a stent?
For the common type atherosclerotic disease right at the origin, the osseous primary stenting is generally preferred. Better technical success, less restenosis compared to just ballooning those osteal lesions.
When might ballooning alone be used?
Maybe for restenosis inside an existing stent, or for non-osteal lesions sometimes, or for fibromuscular dysplasia, which is a different underlying cause.
What if both sides are narrowed? Do they do both at once?
Often, if there's pre-existing kidney disease, they might stage it, treat one side, then bring the patient back later for the other side. Reduces the contrast load and risk of acute kidney injury.
How do they get access? Usually the groin.
Yes, femoral artery access is preferred. Often contralateral, using the groin opposite the kidney being treated, can give a better angle. But brachial artery in the arm, or even radial in the wrist, are alternatives.
And the technique itself, getting the stent in.
Okay, so heparin is given to thin the blood. A catheter is guided up near the renal artery. Then a smaller, selective catheter and a guide wire are maneuvered across the narrowing. A balloon is inflated to open the blockage size to the normal artery diameter. Then the stent, mounted on another balloon, is positioned precisely and deployed.
Which type of stent?
Usually, balloon expandable stents are preferred for osteal lesions because they offer precise placement and good radial strength. For osteal lesions, you want the stent to protrude just a tiny bit, 1 to 2 millimeters, into the aorta. Use the shortest stent possible that covers the whole lesion. Post-dilation with the balloon after stent deployment might be needed to make sure it's fully expanded. Covered stents versus bare metal. No proven difference in outcomes for standard renal artery disease.
What about those embolic protection devices to catch debris?
Yeah, filters or distal balloons. They can be used to try and catch plaque fragments or clots dislodged during the procedure, but none are specifically FDA approved for this indication in the renal arteries.
Do they help?
The evidence is mixed. One trial, RESIST, suggested a benefit only when a filter was used, along with a potent antiplatelet drug, upsiximab. The benefit might be more pronounced in patients with worse kidney function to start with, but it's not routine practice everywhere.
Okay. And after the procedure, what's a follow-up plan?
Monitor closely right after access site for bleeding or pseudoaneurysm, blood pressure, urine output. Keep that dual antiplatelet therapy going. Then, follow-up typically involves duplex ultrasound of the renal arteries.
Looking for re-narrowing.
Right. High velocities, like over 180 centimeters per second, can suggest restenosis. Also check serum creatinine. Usually check at 1 month, then maybe every 6 months for 2 years, then annually. Repeat intervention for restenosis is generally only done if clinical issues reappear worsening BP or kidney function.
How do they treat restenosis if it happens?
If it's early, in-stent restenosis, sometimes a cutting balloon or even a covered stent might be used.
And finally, the scary stuff. What are the major potential complications?
Well, major ones include hemorrhage bleeding, access site pseudoaneurysm, bowel or limb ischemia, though rare, heart attack, thrombosis of the stented renal artery, and acute kidney failure.
Bleeding seems like a big one.
It is. If a patient becomes hemodynamically unstable afterwards, bleeding is the first suspect until proven otherwise. A CT scan can help find the source. Most common is the access site, but renal artery rupture or perforation during angioplasty can happen. That causes bleeding around the kidney, a perinephric hematoma, which can be subtle.
What happens if the renal artery is perforated?
That needs immediate attention. Usually treated endovascularly if possible, using coils or embolization material to seal the hole. Sometimes open surgery is required.
What about the stent clotting off thrombosis?
Rare, but serious. Can happen early or late. Can sometimes be treated with clot-busting drugs or repeat endovascular procedures, maybe re-stenting.
Okay, so putting it all together, if you had to summarize the general approach or algorithm from these texts, what would it look like?
Sure. So indications to consider endovascular repair are really focused. Refractory hypertension, meaning poor control on more than 4 meds, or a documented decline in kidney function over less than 6 months.
Then diagnostics.
Renal artery duplex ultrasound first, usually, then CHA or MRA if kidney function allows, to confirm and plan.
Before the procedure?
Optimize, 5-V hydration, start aspirin statin, hold the specific meds we talked about.
And during the procedure?
Angiography to characterize the lesion. Is it FMD or atherosclerosis? Osteal or non-osteal? That guides treatment. Angioplasty alone, maybe for FMD or some non-osteal lesions. Stenting usually for atherosclerotic disease. Choose contrast carefully based on GFR.
And after?
Follow that surveillance protocol, duplex and creatinine checks. And remember the contraindications, those tricky anatomies, small arteries, kids where open repair might be better.
You mentioned several key studies that form the basis for this understanding. Could you recap a few of the really important ones?
Absolutely. You've got the early trial results like STAR, the first look at embolic protection from Cooper and colleagues in 2008, then the really big, robust investigation CORAL, published in 2014, important reviews like the one by Edwards and Weir, work on surgical repair by Hansen's group, COLRA looking at stenting and advanced CKD, meta-analyses like Kumbani's, and of course the very large ASTRAL trial from 2009. These are really the pillars of the evidence base we've been discussing.
So after this deep dive, it really feels like the main takeaway is, well, the role of endovascular treatment, especially stenting, for renovascular disease is much more limited, much more controversial maybe than you might initially think.
That sums it up well. The evidence just doesn't support using it broadly, particularly not just for treating high blood pressure in most patients.
It really comes down to very careful patient selection.
Absolutely.
Yeah.
Focusing on those specific groups, the severe, uncontrolled hypertension with clear organ effects, or that significant, rapidly progressive kidney dysfunction, where, importantly, there's a real chance of seeing kidney function improve after you intervene. That seems to be the key benefit marker.
It sounds incredibly complex. Weighing potential benefits against the risks, individual patient factors, the anatomy.
It really is. It demands careful judgment, a deep understanding of the nuances in the data, which leaves us with a thought for you, our listener, to ponder.
Yeah.
Given how much better medical management for hypertension has become and these, let's say, nuanced outcomes for intervention, what does the future hold here? Will we see new technologies, better ways to pick the exact patients who will benefit most clearly from endovascular therapy, or will optimal medical therapy become even more central? It's this constant balancing act, isn't it, between our ability to intervene and the hard evidence of whether we should.
A lot to think about. Thanks for walking us through this complex topic.
My pleasure. Thanks for the discussion.